welcome back to my channel. My name is Gia. I'm your friendly family nurse practitioner. And today I'm so excited to talk to you about dizziness. And because this is a common complaint in primary care. Addressing dizziness can feel overwhelming because it involves different systems. But by talking about it today, I hope you feel more comfortable caring for patients who come to you with this issue. So let's get started on understanding dizziness better so you can help your patients feel better too. So there's 4 definitions of dizziness. The first one is vertigo. It is an illusion of self or environmental motion. Most of the patient would say that they're spinning, they feel like they're spinning, or they feel like the room is spinning. The next one is pre-syncope, and this is fainting or almost passing out. Third one is a lightheadedness, and this is when the patient say they feel like they're floating, and this is the more less defined definition of dizziness. And the last one is disequilibrium, which is patient feel like they're gonna fall or they have trouble with balance. So patients may describe their dizziness in various ways, but it's important to approach their accounts with caution as they may not always be entirely accurate. Therefore, conducting a comprehensive discussion and examination is very important. And around 15% of dizziness complaints could indicate serious underlying conditions such as anemia, electrolyte imbalance, acute coronary syndrome, stroke, hypoglycemia, or cardiac arrhythmias. And 85% of the cases, though, are due to less severe benign causes. Okay? So history and physical, you want to ask about the onset. Ask about it, whether the dizziness is episodic versus continuous, the duration, triggered, is it triggered or does it happen spontaneously, any relieving factors, history of trauma, history of upper respiratory infection, any substance abuse and associated symptoms, any chest pain, nausea, vomiting, tinnitus, hearing loss, visual deficits, any abnormal neurological symptoms or deficits, as well as bleeding. For physical, you're gonna perform a thorough physical assessment including the heart, lungs, full neurological exam including reflexes, head, ears, nose and throat, and musculoskeletal system. And so, red flags. As with any complaint in primary care, you want to make sure to check for red flags. And for dizziness, these are abnormal vital signs, any low blood pressure, high blood pressure, low heart rate or high heart rate, abnormal neurological findings, if the patient cannot walk or stand due to severe symptoms, and the D's, diplopia, dysarthria, dysphagia, dysphonia, and dysmetria. So I'm going to talk about vertigo with hearing loss. So if the patient comes in with hearing loss, you're going to suspect otitis media, Meniere's disease, otosclerosis, acoustic neuroma, drug toxicity, perilymphatic fistula, or labyrinthitis. Meniere's disease is characterized by a set of symptoms that affect the inner ear and can lead to episodes of vertigo, hearing loss, tinnitus, and a sensation of fullness or pressure in the affected ear. You can refer the patient to ENT, but you also can advise the patient to adhere to low salt diet, or you can place them on diuretics like hydrochlorothiazide, but you need to rule out serious causes of vertigo. So, vertigo without hearing loss. So if the symptom only lasting seconds to minutes, you're gonna suspect benign paroxysmal positional vertigo, or BPPV. And to diagnose this, you can have the patient refer them to physical therapy to perform Dex Hallpike maneuver, or you can do it in the office if you guys are allowed to do it. And the treatment would be Epley maneuver. And so if the symptoms last for hours, you're going to suspect TIA or posterior brain circulation issues, multiple sclerosis, perilymphatic fistula, or vestibular migraine. If the symptoms has been ongoing for days, so you're going to suspect vestibular neuritis, stroke, maldebarkment syndrome, and this usually happen when a patient just got off a cruise ship or an airplane. So vestibular migraine is a type of migraine headache that also causes dizziness or vertigo, along with the typical symptoms of migraine like throbbing headache, nausea, and sensitivity to light or sound. People with vestibular migraine experiences episode of dizziness or spinning sensations. And the dizziness may occur before, during, or after migraine. The perilymphatic fistula is a condition where there is a tear or hole in one of the membranes between the middle and inner ear. This tear can cause inner ear fluid to leak into the middle ear, leading to symptoms like dizziness, hearing loss, or ringing of the ears. So that's why it's very important to inquire about associated symptoms. It can happen due to head trauma, sudden changes in pressure like from scuba diving or flying, or even without any obvious cause. Treatment may involve rest and avoiding activities that worsen symptoms, and sometimes surgery to repair the tear. Vestibular neuritis is a condition that affects the inner ear and can cause sudden dizziness or vertigo, often accompanied by nausea or vomiting. It occurs because the vestibular nerve, which helps control balance, becomes inflamed or infected. This inflammation can disrupt the signal sent from the inner ear to the brain, leading to feelings of spinning or imbalance. Symptoms usually improve over time as the inflammation subsides, but it takes weeks or even months for full recovery. Maldebarkment syndrome is a rare condition that often occurs, after the person has been on a boat, airplane, or other motion-based transportation. It's characterized by a sensation of a continuous rocking or swaying, even after the motion has stopped. People with this syndrome may feel as though they are still on a boat or airplane, which can be disorienting and uncomfortable. Symptoms typically improve when the person is in motion again, but they return once they become still. While the exact cause of MDS is unknown, it's believed to involve a disruption in the brain's ability to adjust to changes in motion. And I'm going to touch up a little bit about multiple sclerosis. It is also present with weakness, gait disturbance, scanning speech, spasticity, paresthesia, and any GI complaints. So I'm going to talk about benign paroxysmal positional vertigo because this is a benign, like I said, this is benign and accounts for most of the cause of vertigo in primary care. So this is episodic, very brief, like seconds to minutes, and it's triggered by certain head positions. And there should be no spontaneous or gaze-evoked nystagmus and no neurologic deficits. So the treatment is you can trial meclizine for the vertigo, and the treatment is Epley maneuver. And for the diagnosing it, though, is to do the Dex-Hallpike maneuver, like I mentioned earlier. The next one is a pre-syncope, and this is the one that can be caused by more serious condition like hypoglycemia, vasovagal or situational, orthostatic hypotension that can be caused by dehydration, hemorrhage, autonomic failure, cardiovascular, drugs or alcohol, and cardiac causes too, like arrhythmias, structural disease or tamponade, and cardiovascular disease. So your workup depends on your history and physical. If you're unsure though, you can do BMP, CBC, and with cardiac symptoms, you can do EKG, and if abnormal, order a Holter monitor with echo or stress test. And if you're suspecting TIA or stroke, order CT head without contrast or MRI. Does that make sense? So lightheadedness. So for lightheadedness, this is the more or less defined, right? So you're going to check for orthostatic. If it is normal, you can consider psychiatric disorder, considering your neurological, assessment. Other assessments were all normal, right? So you're gonna suspect anxiety, depression, panic disorder, bipolar, hyperventilation syndrome. If your orthostatic is abnormal, you have to check your CBC, BMP, and TSH. And review medications, because some of the medication can cause lightheadedness, such as antidepressant, blood pressure medication, antihistamine, your benzos, antipsychotic meds, opioids, and muscle relaxants. Alright, so the last one I'm going to talk to you about is the disequilibrium. Remember, the patient will complain that they feel like they're going to fall because they are losing balance. Right? And so for this one, it's important to check neuro plus the reflexes, like full neurological assessment. If that is decreased, you're going to suspect peripheral neuropathy, diabetic neuropathy, vitamin B12 deficiency. Can be caused by CNS abnormalities such as Parkinson's, spinal stenosis, spinal cord disorder, and systemic, right? This is systemic. Hypothyroidism, amyloidosis, or brain hypoxia. If the reflexes are variable, you're going to suspect cerebellar disease, drugs, normal pressure hydrocephalus, and this is remember from school that if they have this, they usually would exhibit being wet, wacky, and wobbly, like urinary incontinence. They have some confusion and their balance is off, right? And then suspect tertiary syphilis. If it's increased or the reflexes are increased, you're gonna suspect cervical spondylosis, spinal cord tumor, or multiple myeloma. So your workup here depends on your findings. But like I said, if you're unsure, you can just check for CBC, BMP, vitamin B12, TSH. You can check RPR if suspecting syphilis, MRI or CT of the head if you're suspecting normal pressure hydrocephalus, or you can check X-ray for the cervical. If you're suspecting more of the cervical spondylosis, and other imaging to rule out this, spinal cord tumor, and other labs to rule out multiple myeloma. But if you're unsure, you can refer your patient to neurology, but you gotta do the basic labs, right, to rule out other organic causes. Okay. So I hope you enjoyed this video. I hope you found this helpful. Remember, I'm not just your guide, but also your friend along this journey. If you enjoyed this video, please consider subscribing to my channel. I am very excited to share more videos to support you with your first year of being a nurse practitioner. All right, thank you, my friend, and bye for now.